Hi, team. So, the management of healthcare operations at scale requires a shift from viewing the clinic as a series of individual patient encounters to viewing it as a design system. For many healthcare leaders, the expansion from a single location to a multi site network introduces an illusion of synergy, and that can often manifest as operational drag. This phenomenon that we categorize as the network illusion occurs when local variation is mistaken for flexibility. When individual clinics within a group manage their own intake processes, scheduling logic, and EMR workflows, the organization ceases to function as a unified network and instead can become a collection of small fires, okay? The end of centralized consensus is a primary driver of this fragmentation. Governance drift begins when small local workarounds, and that could be in appointment types, intake logic, or billing queues, are allowed to become permanent differences. While these adjustments may seem minor at the site level, they create a state where metrics lose meaning across the enterprise, okay? And that can prevent leadership from effectively transferring operational wins between locations. And the reality is, a network only begins to compound in value when the core operating logic is shared and protected through a governance layer that ensures information integrity. The first step is going to be moving from micro mapping to macro actions, okay? So, patient journey mapping traditionally is used in service industries to understand consumer behavior, and it serves as a vital tool for healthcare leaders to truly visualize the interaction between patients and complex medical systems. Unlike micro level process mapping that really tracks, every mouse click, macro level journey mapping focuses on high level actions and transition points. Okay, so this allows an approach for a helicopter overview that captures the complete patient experience while still providing enough detail to identify critical bottlenecks. When we do an operational healthcare audit, we look for quiet waste, which are those small reoccurring inefficiencies that act as a tax on your margins. The 30-minute mapping framework is designed to move from abstract ideas, okay, to concrete operational signals by focusing on 5 core domains. That's going to be discovery, contact, assessment, decision making, and ongoing management. By segmenting the journey into those stages, leaders can identify where the system logic breaks down and where quiet waste accumulates. The goal of this mapping is to really distinguish value added time, which is face-to-face clinical interaction, from non-value added time, such as waiting in an exam room or completing redundant paperwork. Research indicates that in a typical 65-minute patient visit, only about 19 minutes may be spent in direct interaction with the physician. Identifying the sources of the remaining 46 minutes is the first step in reclaiming clinical capacity and improving the profit and loss statement. The financial health of a healthcare organization is inextricably linked to the operational burden placed on its clinical staff. Burnout among healthcare professionals is a significant public health concern with direct financial consequences, including medical negligence claims and high staff turnover. The annual cost of burnout in the United States alone is estimated to exceed $4 billion, and this figure reflects the tangible impact of poor system design and chronically excessive job demands on the bottom line. A management-focused profit and loss statement must go beyond standard accounting categories to highlight these operational risks. It should segregate costs into major categories that separate clinical and non-clinical expenses, allowing leaders to see how much quiet waste is being absorbed by the system. Quiet waste, as you know, refers to the small, reoccurring inefficiencies such as underutilized software licenses or redundant administrative tasks that collectively erode margins. When the overall job resources do not match the demand required to achieve clinical goals, individuals become stressed and frustrated, leading to a decrease in work productivity. And this is particularly evident in the use of EMR systems, which are often viewed by physicians as billing tools rather than a clinical improvement system. Okay? The requirement to provide extensive documentation for reimbursement is a primary driver of the digital burden that really leads to burnout. Artificial intelligence, most commonly known as AI, has the potential to actually address these operational challenges by simplifying existing processes and creating more efficient ones. However, and this is a heavy however, the adoption of AI in healthcare can often face a trust but not really reaction from clinicians who are trained to rely on instinct rather than algorithms. To bridge this gap, AI must be positioned as a tool that supports clinical judgment rather than one that replaces it. Here at Occiden, we categorize AI tools into two groups. One is outcome ready and two is P&L ready. Outcome-ready tools perform specific tasks such as summarizing visits or flagging risk codes, but they may still be waiting for a hard dollar ROI to justify their place. P&L-ready tools, they're the gold standard as they don't just work, they pay for themselves by directly impacting the revenue cycle or reducing labor cost. And let me give you a sanitized example. We recently worked with a group where intake times varied significantly between sites, and on paper, both clinics were busy, but one was structurally underutilized because the intake governance was misaligned. And by mapping the macro journey, we could see that the issue was not the team's effort, but actually the way that their software was configured. And by fixing that one governance drift, we reclaimed 20 minutes per patient. All right. So the implementation of AI-driven revenue cycle management is a practical path to convert fragmented data into forward-looking financial intelligence. And by moving from reactive descriptive reporting to an actual signal-driven model, teams can intervene before revenue leakage even occurs. And this shift allows healthcare revenue forecasts to rely on real behavior and operational delays rather than past averages and delayed reports. The current digital landscape in healthcare is really categorized by silos and fragmented pipelines that limit the value of data investments. So by breaking down these silos, they requires not only technological investment, but truly also cultural alignment and shared governance. Data sharing is crucial because it allows physicians to make better decisions and create more informed treatment plans based on a patient's complete medical history. Healthcare right now is being structurally pushed away from siloed systems toward shared data environments where coordination becomes visible and measurable. However, true interoperability depends on the consistent use of standards and a common set of rules for exchange. When data flows seamlessly between payers, providers, patients, referrers, it reduces the need for duplicative tests and minimizes administrative tasks for clinical staff. A critical strategy for managing this transition is really the appointment of what we call a data nurse or a clinical data navigator. And this role is really designed to act as a bridge between clinical practice and financial performance, ensuring that data signals are converted into clear decisions that support patient care without increasing the staff load. Now, if this is your clinic life, subscribe for more operational breakdowns. It's what we do. If you want to see exactly where your margins are eroding, grab the clinic waste self-audit, which will be linked in the description below. It's 100% free. And if you want to find that kind of clarity for your own clinics, the starting point is going to be a short introductory session, and I've linked that below. Thank you.